Fine. So we will start our discussion, and as the topic says, it is on urticaria and angioedema. I'll require your few of the replies when we are doing this class, and that would be a really great help. My first question is, have you seen urticaria? And second question is, have you seen angioedema? Third question is there any difference of urticaria and angioedema? Answer is yes. What is the exact difference? And then we will go ahead. Okay. So I don't want all of these answers right now from you in the chat box. If you answer it, it's well and good. But one thought process will be there, right? I just need that to be in mind, and let's clear it off. Now let me ask one more question before I start. What is your drug of choice when patient comes with angioedema and there is a lip swelling already existing and there is wheezing going on? Okay. That's the first question. Second question, what is your drug of choice when patient comes with severe urticaria on the skin and it's itching too much and patient is restless completely due to that? What is your drug of choice? You have few answers in mind, and I want to make it very clear that how the things are going to work, right? So this chapter as such, we see lot of possibility being asked in your NEET SS exam. Sometime it comes in theory also. In practical exam, sometime on emergency table it comes, and I realize we all were doing it wrong. Okay, so but it's okay. It was going on like this, but this is how it happens. But it may come. If you sometime you can be impressive in those parts. Clinical practice, yes, and when it comes, you have to be very clear how you are dealing, what you are dealing, and things how they are going to go. Everyone is taught on type 1 hypersensitivity. That is more of your anaphylaxis like reaction, because that's the emergency to manage. And what is the drug of choice to manage emergency of anaphylaxis? I think you know the answer, but you can still type in the chat box. Okay, so this is a very brief intro, but I had this thing in line, that why we want to discuss this topic. Okay, because it is not the daily encounter what we see. Okay, so I had few things in mind, and I need one of your answer A, B, C, D, E, F, because most of us do it wrong. I felt it after MD. It is an interesting topic to learn always. Theory and MCQ, why not? They are also important. I'm superhero, I save lives. Just be out of this. Be a normal person and treat like a doctor. This is boring. I prefer to watch a movie. Your choice. It's completely cool. And we love your teaching. You can tell F. Yeah, fine. Okay, so we will start or go further that how we are going to go with this, and the outline of discussion total will be, we'll be first discussing the terminology to understand. Atopy, urticaria, angioedema. There are so many things which are happening, and I feel we should be knowing all this part for that. Then we will go with classification of this urticaria, angioedema, isolated angioedema, and then bradykinin-mediated angioedema, histamine-mediated angioedema. We will go for all this thing. That will help. Then we will see how clinically they present. I will need your help just to Google it. That's all. Okay. I have not kept images today, but I think at that point I will pause and I will ask you to Google the images and take one impression from what you are learning. Okay. So that would be a great break in between. And there are 40 slides. I have to tell it. Fine. Workup and associated condition with this urticaria angioedema. This is a gray zone. It means we try to find who is the expert of urticaria and angioedema. We do not find much answer. There are so many allergy specialists, but the way it is practiced, we feel it very sad that no, this is not the way. I see a lot of commerce there. Okay, and I'm being very honest that still we are not sure who is the expert on this. Let's try to understand and see, because our reflex used to be there. If there is only urticaria symptom, go to dermatology, man. I don't deal it as a physician or the MD medicine. But then you start realizing, no, this is your case in 30% of the cases, and you should not miss it. So that's what I want you to learn today, that what 30% we are not interested in missing, and then I think things should work. And final, we will have our word on management. So this will be the total outline of today's discussion. In between any question, you can drop the message. We will discuss at the end for sure. It is a chapter in Harrison, which is commonly ignored, but it has been given in great detail. So I have tried to optimize it with the recent updates on urticaria and all. I do actively manage chronic spontaneous urticaria, so it's an area of interest for me for sure. Okay, so let's start with a case, right? 55-year-old gentleman presented with swelling of his lips, which started in the morning and gradually progressed over 2 to 3 hours before he presented to clinic. He is hypertensive and on treatment with enalapril and amlodipine. What is your treatment of choice for this patient? IV dexamethasone, IV antihistaminic, IV epinephrine, IV paracetamol. I'm not sure. I have not encountered this case yet. You can write answer. We have, I think, 10 seconds. And someone told me that you should give time to see the answer. Don't go very fast. So I am just waiting. Okay. Diagnosis wise fine. Enalapril induced angioedema. But patient is always concerned कि diagnosis pata hai. Tell me the treatment. Out of all the options, or you can mix it or something. Okay, antihistaminic and stop as IV epinephrine, fine. Anything else? IV epinephrine, one more answer, good. Okay, majority answers are IV epinephrine. I completely do not agree here, fine. Okay, so we will see it, and I think at the end of class, go back to this case and try to see what actually should happen. And what you have told right now is the reflex is the right thing to do when patient comes. And I won't deny that specifically if there is a respiratory compromise. We will go with those part. But we are going to understand more of the basics that will clear our treatment principle very clearly, that what ideally should be done if the IV epinephrine does not work for this case. Okay, that is my only concern. It may not work. What next? Steroid? I have already given an option. Give it, and we are going to give anyhow, right? Steroid, antihistaminic, and epinephrine. People give it very fast. We all have been trained very good with anaphylaxis management, starting from MBBS, I think. Okay, so it should be a reflex. There is no discussion here. Okay, that we give it. But what if patient does not improve? There comes your understanding of the subject. Okay, and that's what is the total focus here. That's why I told that I completely do not agree to this, but to the certain extent I agree with the practice, and I also do this in my practice. Okay, but we will go further. So now we start with the main parts. The first part I told I will go to terminology, and then I'm going to classification. It's going to be more of theoretical class, but we will try to see how clinically they are relevant in an overall sense. Okay, so when we use the word atopy, it is overall hypersensitivity, which is IgE mediated. You are talking allergic rhinitis, asthma, atopic dermatitis, urticaria, all these things alone or in combination is termed as atopy. So when sometime in your respiratory coughs of asthma, rather than mentioning no history of rhinitis, urticaria, atopic dermatitis, sometimes you can tell there is no history of atopic disorders in the family. If your examiner is sound enough, and they will get it what you are trying to tell. Atopy is an umbrella term or a broader term to define all this thing. Then there is a sensitization concept. I'm not going much into that, but yeah, first exposure gets sensitized, second exposure gets activated, and it's a subsequent antigen specific mast cell activation, and then the allergic reaction. More it is described for the type 1 hypersensitivity what we talk. Now the 2 point what we are going to discuss, urticaria and angioedema. Now, what is the key difference of urticaria and angioedema? Urticaria is a visible red rash, which is sometimes elevated and pruritic. Angioedema is a visible swelling, which is visible mostly on the mucous membrane, including tongue, lip, and all part. Okay, so it's a major difference is this. So what is the level of difference? So the urticaria is involvement of the structure at superficial dermis, while your angioedema is involvement at the deeper dermis and subcutaneous tissue. Now, these are very simple points, but it helps me like great. Okay, that I can imagine my pathogenesis, etiology, and everything very easily, what level of vessels are involved and how things are happening here. So both are little different, but both can coexist. That's called urticaria angioedema together. That's fine. Okay. So there can be just urticaria, there can be urticaria angioedema, or there can be just angioedema. Now, angioedema without urticaria is the most challenging case for any physician. And that's what I want you to learn today. Okay. For urticaria, what I've figured out, my dermatology colleagues are too good. And mostly I solve cases with them and it works. Okay. When it comes to isolated angioedema, No one is expert on that. Only few are there. I know few. So I actually asked them from PGI and all that I have been with this case, how we are going to go further. Okay. Urticaria usually lasts less than 24 hours. It is frequently migrate around the body, leaves no bruising or scar, and it is intensely pruritic. Okay. So it itches a lot. While angioedema is more of swelling, it is pain, swelling more than pruritus and minimal erythema, and it can develop with the prodrome, pruritic prodrome and all. Okay, so this is more kind of a difference what we are realizing, which is at a tissue level, which can happen in urticaria and angioedema. Now, see, I have demarcated one part. The urticaria lasts for less than 24 hours. I have now one question for you. What if the urticaria lasts more than 24 hours? What should come to your mind when you have a patient who tells my urticaria lasts for more than 24 hours? And again, as the class goes on, you will be able to solve this part. But I always have curiosities that why this is something which is, does it carry any importance why they are telling less than 24 hours? What if it is more than 24 hours? And you can always reply. I am more than happy to receive replies even if they are wrong. Okay. Urticaria lasting more than 24 hours. And believe me, if you know this fact, you are going to make difference in your clinical practice. That's what I want you to do always. That's the case. I do not refer to dermatology very fast because it has systemic causes. We'll come to that. Now we will go after terminology to classification. I'm going to spend some 6, 7 slides on classification, maybe little repetitive, but it is required to understand from very starting. The urticaria we divide in acute and chronic depending on duration. So if it's less than 6 weeks, it is acute urticaria, and chronic, it is usually more than 6 weeks or more than 26 weeks it is going. Okay, it's more than 6 weeks. Then we go for the chronic urticaria. Okay, now chronic urticaria means a patient has urticaria symptoms for more than 6 weeks. Now, before I go here, the information is following beyond, but acute urticaria are mostly secondary to some infection or drugs. They resolve with the symptomatic treatment, so we should not worry much. But if the urticaria symptoms are more than 6 weeks, we have to think whether they are inducible or spontaneous. Okay, so inducible means you have a definite known trigger and which has relation to the activity like pressure, cold, or cholinergic, or some food or drug, something. So it's an inducible urticaria. Okay. While the spontaneous is something that there is no external specific trigger. Believe me, this is a common case, but which is always treated like an inducible by doing so many allergic test, allergen test and all, by changing the lifestyle, by changing the total interior of the home. It costs so much and patient still is not happy. Okay. Because we are not in right line. Okay. So it can be sometime unknown cause, which we tell chronic spontaneous urticaria, or sometimes they can be secondary to autoimmune and very rarely secondary to infection. See, now this is important point that, okay, this is just skin symptom and we still have a mind, okay, refer to dermatology. Okay. But for today, try to understand as we cannot refer cases in NEET SS. Okay. That day we have to answer it. So try to understand. And I think after this, you will be more, let me at least ask history, keep my differential, and then refer to dermatology, because there is a chance patient may come back to us telling there is a systemic involvement, which you need to treat, doctor. Okay, so this is the part we are going for. This is a very simple classification. This is depending on the duration and depending on the trigger is there or not. That's the first way to classify urticaria. Okay, now this is what we can see, that you have acute urticaria, usually less than 6 weeks, chronic spontaneous urticaria or chronic inducible urticaria, which is more than 6 weeks. Over. This is something what we have known in the previous slides. I'll keep it little repetitive because it's dermatology, right? So that's what we are little more interested how the things are going to go for. Okay. Now what I have written is angioedema. Okay. That classification of urticaria and angioedema, how we should go for acute and chronic, or what are the associated disorders. So in acute, mostly they are drug reaction related to food, inhalation of contact or environmental antigen, transfusion reaction, insect, or infection. While in the chronic, you have lot of things to deal. It can be idiopathic, it can be connective tissue disorder like arterial vasculitis. That was the clue and someone answered it very correctly. If the urticaria lasts more than 24 hours, you have to think of urticarial vasculitis. They can be inducible urticaria by the physical stimulus, cholinergic, vibration, and all. So that is also one possibility what we are looking at. The possibility of mastocytosis and urticaria pigmentosa is something we have to be very careful, because they are more of a medicine or the hemat-onc case. It is a mixed area. Again, we both deal with those cases with rheumatology. Then you have hereditary cases of hereditary angioedema, familial cold urticaria, and Muckle-Wells syndrome. These are autoinflammatory syndrome and all. We will come to that little more. Schnitzer syndrome, hypereosinophilic syndrome, and Glaze syndrome. Okay. Now I just want you to Google what is Glaze syndrome. It is in your Harrison. Okay. And sometime it comes that what this symptom means. And most of the time, it is recurrent fever with eosinophilia with urticaria. Okay, that's a very important thing to know, because they will ask you all of the following the part of Glaze syndrome except. Okay, when it is there in your Harrison, it is to be known. Okay, that's why we deal it. Okay, so now first we saw there is acute urticaria, chronic urticaria. Acute, the secondary causes are like this. The chronic secondary causes are like this. Okay, and in chronic we have two part, which is this is inducible, and these are secondary, and these are few which can be hereditary and all part. Okay, so either it can be spontaneous or inducible, and in spontaneous you can have either the secondary causes like the connective tissue disorders and all, and then there can be the other things which can be happening with this part. Okay, now these are inducible urticaria. I am not going much into the detail here. I just need you to focus on this part. Okay, it can be either a pressure related, cholinergic, cold induced, heat induced, exercise induced, aquagenic, solar, and vibratory. So you have to ask all this history as such, that what are the exit triggers, and sometimes patient do not tell. I recently saw one patient who was being treated as a Raynaud's phenomenon, but what I found that she has cold induced urticaria or cold contact urticaria. Now the thing is she is gynecology resident. So it is so difficult for her in OT and all to deal those things, and that is something you have to tell avoidance, right? So you start antihistaminic, try to avoid as much as possible, but few things cannot be, but it has to be modified. What was my clue of Raynaud's phenomenon versus cold contact urticaria? Not classic history of Raynaud's. She was already being treated for Raynaud's and did not improve. And she told me those things happen on the forearm and arm also whenever the cold object touches. Raynaud's cannot happen there, right? So this was very easy case for us. What was missing actually? Just a history, inquiring, and I think that's what Sudha ma'am told. That's a skill we have to develop, or the time. Just ask and you solve cases. So she was already on tadalafil and nicardipine. Now she is just on antihistaminic and avoidance of the cold whenever is possible. I'm still trying to find why at this age she has developed cold, uh, contact urticaria or cold induced urticaria. I will come to those parts. Sometime it is important and we are working upon that. Okay. So this is just a show up slide that, okay, whatever we are talking about, there are too much immune mechanism which are associated with urticaria or the angioedema etiology. Today, I'm not going into those details. Someday we will enjoy the immunology, but today we'll keep it to more and more clinical part. Okay. So till now you understand there is a acute and chronic urticaria depending on 6 weeks. In chronic, there is no known cause. We tell it chronic spontaneous urticaria, and then there are associated conditions like connective tissue disorder and the other parts. And there is one thing which is called chronic inducible urticaria, where you have definite triggers. So this is how we are going for acute, chronic, spontaneous, inducible. And in spontaneous, it is either with no known reason or something else with a known reason. Okay. Now, this is what I was talking till now was on urticaria and angioedema, which is more histamine related. Now what I'm crossing here is bradykinin related. Okay. This is the major difference. Now let me put you a simple question. What is the possible etiology of your this patient what we discussed who had enalapril induced angioedema probably? Is it histamine a culprit or a bradykinin a culprit? I need a very simple answer. I think you all know it. So shoot your answer in the chat box. That ACE inhibitor induced angioedema, it's related to bradykinin or histamine, or someone is thinking both. It's okay. I like to do this. Okay. So you can give your answer and we will go till now in this. Now see, your bradykinin mediated angioedema syndrome are pure angioedema. This is a very important thing you have to remember. They do not have urticaria. So when you get a patient with recurrent lip swelling, hand swelling, or the tongue swelling, or the periorbital swelling, but no itching, no rash, no urticaria, think it is probably related to bradykinin. Okay. So if this is due to what we say the C1 esterase, C1 inhibitor deficiency, right? So, and the gene for that is a SERPing1. This is your MCQ part. So if there is a complete deficiency, what we say, it is type 1. If it is just mutation causing functional problem, it's type 2. Sometimes the C1 inhibitor level can be normal and still it's a hereditary angioedema. Okay, so these are the 3 points. Then there can be acquired causes of C1 esterase inhibitor deficiency. Then it can be related to what we discussed, ACE inhibitor, and sometimes it is idiopathic non-histaminergic angioedema, which is happening there. I am not going right now in all this detail. This is more, it helps in MCQ, what happens to complement level C4 and C1Q, but we will come to this as an approach. Right now, I just wanted you to know the classification. Now we have progressed little well. We started with the urticaria angioedema, which are histamine mediated, which can be acute if it's less than 6 weeks, chronic if it's more than 6 weeks. If there is a non-inducible trigger, we tell it inducible urticaria. Otherwise, we keep it a spontaneous urticaria. They can be sometimes associated with the connective tissue disorder, infection, or some hereditary causes. Okay. Now we come to something called bradykinin, and bradykinin mediated disorder are pure angioedema, which can be either hereditary or acquired or drug induced or idiopathic. This is how the total story goes on, right? So this is very important to know because we have to be very clear. Now I want to introspect and think about my first answer when I told, when I have a patient who has a angioedema on enalapril, what is your drug of choice? If you were telling epinephrine, if you were telling steroids, or if you were telling something else, does it really address bradykinin related problem? Answer yes or no. Think more and you will see, oh, it may not, right? And it does not. So we have to be again very careful that why all these things are important to understand. Because tomorrow I am going to start an enalapril for one patient. He comes with lip swelling. Sir, this is what it happened after your drug. What I'm going to do? Stopping enalapril? Yes, I will do that. But what if that swelling is in the throat? What I'm going to do here, right? So this is a very important point what we are going for. Now we will come to the third phase of the class, which is clinical presentation. Okay. So till now, I put one question for you. Then we discussed few terminology, and then we went in a proper classification. Now I want you to come to the ward or the OPD or the clinic or the emergency and think what can happen and how your patient will come to you. Okay. So the question here is for you. How does the urticaria present? Now, the one very good clue is a distinctly pruritic lesion. I recently had one reference for a patient who had urticaria and this kind of symptom. Now, this patient never told she has pruritus, and I was completely fine कि नहीं यार ये urticaria नहीं है. It is very unlikely you get urticaria without pruritus to start with. Okay, so we have to always question. There is some problem, but I'm pretty sure this is not urticaria. Then what is the problem? My total approach changes there. Okay, so this is very important point we all have to keep in mind. So that involves any area of the body, scalp to sole of the feet, everywhere. They appears in the crops, and old lesion fades away as the new one appears. Okay, so if you have seen 1, 2, 3 or any number of patient of urticaria, you have to actually ask that what was happening to you. So they will tell ki it was itching too much. Then we notice in the legs, those lesions were there. Then it came in my back. Then it was in the upper limb or somewhere. It was everywhere. Okay, sometimes they will tell like this. Usually they last for 12 to 36 hours, less than 24 hours, the routine rule. But the physical urticaria, specifically cold, cholinergic, and dermatographism, usually last for less than 2 hours. A very good clinical clue, but we know that dermatologists will do it, right? So keep it to the MCQ. Fine. Okay, but keep it to the MCQ. This is very important. Now, chronic urticaria, 45% patient have some autoimmune cause, and that we need to prove. Most of the time, it's a Hashimoto's thyroiditis we keep looking for, and we actively investigate for that, though TSH is normal, because treatment may change little. So this is something we have to remember this part. Okay. Now, what I want to do is see two more slides, and after that, open your Google part. Okay. So now, second is angioedema. What is the exact thing written here? It's a swelling of more of mucous membrane than the other part. But we have seen angioedema in the hand, spit, and all, where there is no distinct mucous membrane. Okay, so we tell it's a subcutaneous plane which is getting involved in the mucosa, which is getting involved, which is leading to this angioedema. You usually see it in eyelid as a periorbital swelling. We all know, if you ask, if someone asks you what are the causes of periorbital swelling, angioedema, what we will answer, right? That is important. Tongue, yes. Lips, yes. Pharynx, dangerous. Larynx, dangerous. Intestine, sometimes it can present as diarrhea. Okay, so it's a very important thing. We get a clue. This is a angioedema. What are the most common site? Periorbital and perioral. These are all our MCQ point. Angioedema of the upper respiratory tract can be life-threatening, and for GI involvement, they can have colic without nausea or vomiting, and sometimes it can result even in unnecessary surgical intervention. It happens, right? Without proving, it will be very difficult to tell very confidently that no, this is angioedema, man, don't operate. Okay, it is very difficult to take those kind of call. But when your diagnostic evaluation is completely normal, then it is worth taking this call by giving a proper treatment. Okay, and you know, right, medical causes of abdominal pain, and we all know angioedema we have to write. Okay, hyperparathyroidism we have to write, lead poisoning we have to write, diabetic ketoacidosis we have to write, porphyria we have to write. These are medical causes of abdominal pain. I will tell even polyarthritis nodosa, which can have mesenteric vasculitis and all. We have to write these causes because these are medicine case, and sometimes we confidently refer surgical reference. Okay, it's not like that. We have to solve it. That's a major clue. When you're referring, at least you have to stay in coordination that what is happening to this case. I know it is a difficult task, but sometimes we have to. Okay, so this is angioedema, and now I need a little break. Okay, I need you to Google urticaria. I need you to Google urticarial vasculitis, and I need you to Google angioedema. Okay, we are waiting for 1 second, or not 1 second. That's not enough, right? 15-20 seconds, fine. Try to Google. Everyone has 4G, 5G, right? So try to Google how the urticaria looks. They are more on skin. They looks like whales. And sometimes you will see this photo of dermatographism where people will write their name and all on the skin, right? Then if you write urticarial vasculitis, what will be happening is there will be little raised lesion. They last for 24 hours or more, but it won't be on Google, right? It is the image. The important point is when a urticaria heals, it does not leave scar, it does not leave pigmentation. When urticarial vasculitis heals, it leaves pigmentation. Okay, that's a very good clinical history. That urticaria, which lasts for more than 24 hours and heals with pigmentation, is likely to be urticarial vasculitis rather than just spontaneous or the plain urticaria. Okay, and then when you Google this angioedema, you will see swelling of the periorbital, you will see the swelling of the lip, you will see the swelling of the tongue, you will sometimes see the swelling of the hands and feet also. I had one kid who had hereditary angioedema, and his recurrent symptom was swelling of the hand. And that was a very major clue for me. It's a bradykinin, not antihistaminic. And the very important thing which happens in specialty practices, mostly you get referred cases. So everyone has tried steroid, antihistaminic. It did not work. Again, a very good clue. I am dealing with the bradykinin mediated angioedema. Use everything when you do your clinical practice. It is not others' mistake. It was others' first line treatment which did not work. Okay, that's how the clinical practice is done. So never criticize, just practice where the patient has come to you. From that point, he or she is your patient and you deal with that. Don't criticize. There is no time for that. Okay, so this is a very important lesson what we are taking. And again, I hope you have Googled it, and then we are going ahead. How do they look and how the things are going to work? So now you know something like there is something called urticaria, there is something called angioedema. Both can occur together. That's urticaria angioedema, or angioedema can occur on a isolation also. Okay, so it's a very important lesson you have learned today. And then you know if it's more than 6 weeks, less than six weeks. more than 6 weeks, with trigger, without trigger, associated condition present or not. That's all. That's a total classification. You have to put your patient in, and then you can easily do the workup and management. That's how we manage these cases. I have learned most of the urticaria angioedema with my dermatology colleagues, thanks to my training in Jaipur, that I could learn too much with this part. And later on also, I have 2, 3 dermatologists right now in very good contact for this urticaria angioedema case, because we solve it together and it is fun. Okay. So now I'm going to go to the very important slides, which as a physician, I feel if we know this, we will be one level up to the other physician. Okay, so that's what we have to be sometime, right? So one is histamine mediated angioedema, and second is bradykinin mediated angioedema. What are the key clinical difference? And now I really want you to Google, write bradykinin mediated angioedema, write histamine mediated angioedema, but let's focus it here. You can do it a little later. So now here it is more of an allergic reaction and is mostly associated with the urticaria. Here mostly they are related to, in our clinical practice, ACE inhibitor and sometimes even ARB can cause. And what are the other drugs which can cause this bradykinin mediated angioedema? Can you list few at least? It can be triggered sometime by minor trauma also. This is the first, the trigger. The second, which is very important clue in my clinical practice, if they are everywhere, probably it's a histamine. Diffuse, symmetrical, and more often involves lips and eyes. It is mostly we are dealing with diffuse is more histamine. If they are focal and asymmetrical, I told that I had a kid who had just right upper limb recurrent swelling or the right hand recurrent swelling. Okay, and it oftenly primarily involves tongue. The eyelid involvement, lip involvement, you can compare the percentage, not much important here. The laryngeal involvement is more, but more it is something distribution. Only angioedema, think bradykinin. Asymmetrical, non-diffuse, think bradykinin. This is how you go in your clinical practice. You have a patient with lip swelling. I still remember one of my patient who had lupus nephritis, and I started treatment with all steroids, cyclophosphamide, and everything. Okay, and as an antiproteinuric, we used to give ACE inhibitor for the hypertension. We use enalapril a lot. Okay, this patient distinctly came with the lip swelling, and she was hiding it because it was more of a stigma for her that she didn't want world to see that the lip has been swollen like this. Okay, an immediate clue was this. We stopped and it worked, but if it did not stop, what was our next plan? That's what I'm interested in learning. Okay, so first is a trigger. Now see, this lady came with the lip swelling without any skin problem, so I cannot label it urticaria angioedema. I have to label it angioedema, which is probably bradykinin mediated secondary to ACE inhibitor. Okay, that was our case. Fine. So now the next slide, the differences. Okay, it evolves very fast. You remember our case that the patient started noticing swelling of the lip, which evolved over 2-3 hours. Now, the history is such a beautiful thing in medicine. If you take it, it makes your diagnosis, right? So it evolves slowly over many hours. These are mostly associated with the urticaria, while here there is no urticaria or pruritus. That's again a second very major clue. Okay, if urticaria is there, mostly it is histamine, your antihistaminic steroid or epinephrine is going to work 99% time. Okay, you might have to repeat it, but it's going to work. But in this case, they are less likely to work. Okay, here erythema is very common, itching is very common, while it is very less common in this kind of cases. Here, mostly it's anaphylaxis context, the other organ can be involved. Here, usually other organs are not involved, but sometimes diarrhea can be there because of the GI involvement and all that. Okay, so it's again a very good clue. Now, response to therapy is again important clue. It responds to epinephrine, antihistamine, and steroid. Unresponsive to this, but 2 to 10% can respond. That's why I told you that I partially agree with you. I will give it. Okay. But if it does not improve, I should have a plan B. That is very important. Actually, it's a plan A. But I'm working on plan B, whether patient is responding or not, because the correct therapy is going to take little time to arrange from blood bank. Okay, so I'll come to that. This is what we do in clinical practice, that this clue can be used. If it's a histamine mediated angioedema, they will respond to antihistaminic steroid and possibly epinephrine. If they are bradykinin mediated, they won't respond. They progress slowly over a period of hours. These are the differentiating point. Immediate therapeutic response to steroid or antihistaminic or epinephrine is a very good clue. Again, you are dealing with histamine over bradykinin. So my total class, I am deviating to you. Decide whether it's a histamine or bradykinin and do a little show off that this works and this does not work. At the end of class, you should be able to learn and do a little show off. Okay, fine. Okay, so this is the overall approach. Whatever we have discussed till now, you understand little terminology, what is atopy, what is sensitization, what is urticaria, what is angioedema. You understand classification. Now you even understand the processes. It can be either bradykinin mediated or histamine mediated. If it's just bradykinin mediated, it is likely to be pure angioedema. If it is mediated by histamine, it can be pure urticaria or urticaria angioedema. If your urticaria is lasting for more than 24 hours and leaves pigmentation while healing, it is probably urticarial vasculitis. Wow, you are doing really great job. Now, urticaria, you know more than 6 weeks, less than 6 weeks, and you know the game total. And that is what, if it's urticaria, they are mast cell mediated, and mostly your treatment with steroid, epinephrine, and things will work, and antihistaminic for a longer time. If it is still stays omalizumab and all comes in the picture, I will come to those part also a little. Okay. But if your patient does not have urticaria, okay, the first question is, in our clinical practice of adult medicine, are you on ACE inhibitor? If yes, stop, and the part solves, label it, and then do not give it again. If it does not solve, the first screening investigation is complement 4, because that's where the differentiation starts. Okay, but we will not go more in detail. But in MCQ, for hereditary, like for a bradykinin mediated angioedema, if they are not drug induced, what is the first investigation of choice? It's a complement 4, C4. We have a habit of sending C3, C4 together. Here only C4 makes sense, C3 does not make sense in a more of differential diagnosis there. Okay. Now, if C4 level you are going and it is low, then you will go for the C1 inhibitor level, or the this. If that is low, you will go for the C1q antigen level. If that is low, it is acquired C1 INH deficiency, right? If it's normal, it is type 1 hereditary angioedema. So low C4, low C1 NH, but normal C1q is a part of type 1 hereditary angioedema. I'm not going much in detail, but this is how you follow. In clinical practice, mostly we will stop here. Okay. And sometime we go here. If it's normal, sometime it can go to idiopathic, or sometime it can be hereditary angioedema with normal level of C1 inhibitor, and it comes further that it is going. Again, when you label it idiopathic, assess with the antihistaminic response. If yes, you can say there is a mast cell mediated component which is present. If no, then it is non-histaminergic and bradykinin. I know this is a tough table. Okay, but what you learned today, C4 is the first investigation, C1 inhibitor is the second investigation, and C1q antigen is the third level to assess. Now, if you ask any lab, they will be very easily available C4. For your C1 inhibitor and C1q, you have to do little homework, and then you have to get, okay, is it available or not? It's a beautiful table in clinical practice. Most of the time, you believe me, I just end here and I play here. Very few time we go here, and very few time we come to type 1 or type 2. Okay. In type 2, the difference is your C1 inhibitor level is normal, but the function is low. Okay. So again, you need a functional assay to prove that. And believe me, these are not easy things. That's why I make a good diagnosis. I start treatment, and for evaluation, I refer to the higher institute like PGI and all. They work very focusedly on this hereditary angioedema and all with pediatric immunology department. So they are my good friend to solve the cases. Okay. So this is what we have to do. Okay. It's not something you make a good clinical diagnosis and then ask help from the colleague that how we can prove it rather than doing everything ourselves. It's not worth some time. Okay. So how do we investigate, right? So now we know one part, which is terminology, second part, which is classification, third part, how do they clinical present, and the fourth part, what was the overall approach there. Okay. Now, if you have this patient, how do you actually evaluate in your clinical practice? Refer to dermatology. Okay, remember this, you take their help together. I always take the burden comes down at the end of day, and the diagnosis gets even more specified. Okay. So first remember, acute urticaria. Why we call it acute? Because they are in less than 6 weeks. So you understand by this thing that mostly they are self-limited. So you are not going to push for allergy evaluation till the 6 weeks are over. You are going to treat them symptomatically. If episodes are happening beyond 6 weeks, then there is a point you are going to evaluate them. Okay, this is a very important point in clinical practice. All acute urticaria, you are not going to do IgE level, allergen test, this many antigen tests, allergen specific IgE. Don't do that, please. Wait. Okay, so it does not require routine or extensive diagnostic test unless strongly suggested by the patient history, whether there's a food allergy or the drug hypersensitivity. And there also you can see that it can occur together. And in this cases, if you have done allergen test, it can help to avoid the trigger again and again. But a very important point, we have to remember the context. I was mentioning about one patient who was referred who did not had urticaria itself. Sometimes we get reference, but you have to prove, or you have to start with not believing the referred diagnosis. That's how medicine is practiced. Make your diagnosis. Okay, so it's a very first point. Now if you got the diagnosis, see the overall scenario, whether there was a specific drug or patient was sick before that. That's the infection many of the time. If yes, wait, please give antihistaminic. Okay, aram se, don't worry. Give for 4 weeks, 6 weeks, nothing will happen. Okay, but after that, withdraw and see whether there's a recurrence. If recurrence, then we know the plan. Now this is chronic, and then how to go for that. Okay, that's a very important. But if there is definite food induced or something, you can do for this allergen test, and you see that what are the exact sensitive part, and those are the things to be avoided. Now the worst part about this allergen test is something, many of the allergen come positive as allergy, though person is not allergic. If I do my test and it comes I'm allergic to milk, I won't stop milk, right? Come on. So that's why history is very important when you do the counseling with the allergen test. Had you ever had milk in your life? Yes, everyday doctor. Anything happens, nothing happens. Avoid the test, ignore the test. Okay, that's not the culprit. You have to find the correct culprit with the history. Only allergen test. I have seen few patients who have not taken milk for 6 years because they found this test which was done in some screening. It's completely useless thing. Okay, if the history is not correlated with this part. So it is very important. Why I'm telling is we are relying so much on IgE level. We are relying so much on those allergen test, a big card which is given with some 16 antigen or sometimes 24 antigen or something, or allergen what we tell. Okay, that's not the case. Don't go there. Okay, if you're going there, be sure about all allergen, you know how to ask the history, and then you go further whether you are going to go for the further evaluation is not. Okay, there is a lot of commerce. Okay, so I'm just giving you a red signal that don't go or don't be prey of a investigation. So acute urticaria, as I told, most it is associated with the infection in many of the cases, and less frequently they are associated with the drug, inhalant allergen, food, stress, and stings, and the physical factors. Okay, stress is also cause of urticaria. It's okay. We cannot say all the time. Okay, we are talking after the this mental health day. Okay, fine. But this is something what I wanted to point out. Wait and treat symptomatically when the duration of urticaria is not more than 6 weeks. Wait. Okay. After that, you go for further. But whenever I tell you urticaria, be sure these are urticaria which heals usually within 24 to 36 hours, and which heals without leaving the pigmentation. If they are leaving pigmentation, they are already urticarial vasculitis. Approach is little different. Okay. So now go to the next part. That's a chronic spontaneous urticaria. Now, chronic spontaneous urticaria means patient does not have a definite trigger or something. They told it just happens. And many of the time, this is the case. And we try telling that now avoid the dust, avoid this thing, avoid that thing, because we are also not sure what we are doing, right? So be very sure. If you do not find a trigger with a thorough history, try to label it chronic spontaneous urticaria, because here you can offer a lot of treatment and you can save a lot of money by not doing too much investigation. One, second, by not changing their home interior, all the bats, dust, and everything, and doing the right counseling and allowing them to live a normal life, which involves taking all the foods. Okay, that is very important, because they will say, I stop nuts, I want stop milk, I am taking now soybean milk. What you are doing with your life? Okay, it's not needed, it's spontaneous. And then say, sir, I have stopped it, still I think it is almost same. or sometimes that placebo effect comes. Okay, I feel there is a 20% relief. No, man, 20% is not a relief I want to live with in my life. Okay, so this is a very important point we have to consider. Listening to the patient, they did all the modification. Did it work? No, you are going for spontaneous, and right, very bold, it is spontaneous now. Okay, in this spontaneous also, if you do that allergen test, it may come positive. Okay, don't do this. Okay, it's not required. Fine. So basic test here include, I told, autoimmune etiology is very common. So you do the differential count, see for the eosinophil, ESR, CRP, IgG, anti-TPO, and total serum Ig level. These are very important thing. And then further testing if it is indicated, what further testing which may be needed. Okay, so you should know what are the associated condition with the chronic spontaneous urticaria. Okay, it can be autoimmune disorder like thyroid disorder, vitiligo, RA, autoimmune gastritis, and diabetes mellitus. Treat them. They will be obvious. Okay, if patient does not have much of joint pain and all, no point of sending RF and anti-CCP. Does not make sense. Even if they are positive, it's not rheumatoid arthritis. Okay, it's autoimmunity, but not autoimmune disease. That's a difference. Okay, that we have to know. It can be sometime with Helicobacter pylori infection, and I do it very properly if there's a dyspeptic symptom, because if that is eliminated, urticaria part disappears. And I have faced few patients who has now complete relief of that. So I do this very actively if patients are symptomatic, or I ask my gastro colleague, do you feel it is worth? Because you can just do the screening with the urea blood test and you can get away with that. Okay, that's a very important. Do not treat empirically, right? It's a test and treat approach. Sometimes they can be with cancer, but they will be too much. Okay, it is just 0 to 9% of patient, mostly non-hematological cancer. They will have other clues and you will identify cancer by this, not by urticaria. And some mental health disorder, their association, not the complete thing. Okay, they have mostly depression and anxiety. Sometimes they're secondary to their urticaria. That's life is terrible. Okay, I have one patient who is a professor, and she tells that in my class, in between, I have to just eat. Okay, that's so terrible. If it's a Diwali or any function, I just have to do eating more. So she takes steroid herself to prevent that part. Okay, but if you rightly guide it, it works. So this is one part. When you do not have much of the trigger in chronic spontaneous urticaria, you have to look very actively. If these are not found, again label it primary chronic spontaneous urticaria and make a management plan, either with your immunologist, rheumatologist, or dermatologist who is good at this part. Okay, this is one part people are not comfortable, and this is one we need to discuss more and more. I told this arterial vasculitis, right? Last more than 24 hours, and the biopsy shows this, and very important, it leaves pigmentation at healing point. Okay, so these are the very good clue what you can get for the arterial vasculitis, and this is how it works in clinical practice also. When you see arterial vasculitis, there is something called hypocomplementinemic arterial vasculitis. Now, the beautiful thing is, with this hypocomplementic arterial vasculitis, what are the associated feature? You know, it can be uveitis or it can be COPD. Okay, a very important thing. When your COPD patient has urticaria or the arterial vasculitis, you might be dealing with hypocomplementinic arterial vasculitis, steroid in COPD. This is the role here, one proven. So again, a very important point. See, that's what I really want you to be a very good physician who has read Harrison. Okay, because this is only you can make this diagnosis, right? COPD patient will not come to a rheumatologist. COPD patient develops skin problem, you will not send to a rheumatologist. You will send to a dermatologist. Fine. But did you make a connection? My all COPD patient do not have skin problem. Why this patient has? Okay. And then we will say milk, peanuts, and all. Don't do that. Okay. Prove it. Specifically, if it's arterial vasculitis, prove it, because you are going to a very good diagnosis here. They have low C1q level, they have low complement level. That's why they are hypocomplementinic arterial vasculitis. You can make a diagnosis. Okay. So take help, but start thinking. That is important point of being a physician. Fine. Second, I told there can be some patient who can just have angioedema, or they just develop wheals but not angioedema. This is one case I really want to discuss, because this is what I told, that I diagnosed this cold-induced wheals or cold-induced urticaria in that resident. That lady never had angioedema. She had just cold-induced wheals. Raynaud's phenomenon was wrong diagnosis. We just discarded, and we even do nail fold capillaroscopy to make sure that it is normal. It is usually disturbed in Raynaud's phenomenon, while your nail fold capillaroscopy here, what we see under dermoscope, or there is an NFC video machine, If that is normal, it is unlikely to be RP. Okay, so that was very good clue for us. It is not RP and this. And now this lady told that along with this wheels and all, she has fever and intermittently her CRP and ESR was elevated. And that's the point I started thinking of, am I dealing with autoinflammatory syndrome or not? Okay, so that's how the things makes connection. When I was preparing this PPT, I could remember, okay, everything makes sense of reading because this I might have read some 3-4 years back, and I think 3-4 weeks back, this patient came and I was, yeah, I can think of this. And that's a good point. So I talked to my dermatologist again. There's something called autoinflammatory syndrome. I'm thinking in this lady, but first prove me what is dermatological diagnosis. So she told, okay, it is cold urticaria. So now we are working cold urticaria plus fever plus CRP and all in an episodic manner. Are we dealing with CAPS, that's cryopyrin associated syndrome, or there's something called FCAS, that's a familial cold induced urticaria associated syndrome. Okay, so these are things which are there in your textbook. You see it in MCQ, and they come to your clinical practice also. I have not proven the case yet, but my working direction is very clear. This is how I am going to go for this lady. Okay, so we will see the response, and as she comes, we will plan the genetic testing and we will see further how it goes. So what I'm trying to make you realize is they are not pure dermatology cases. Nothing is pure cases. Medicine is involved everywhere, and actually enjoy that part. Okay, we have a lot to do as a physician and we can do a lot. Okay, so please do it. Please enjoy it. Okay, don't keep referring. Fine. Next part comes is the chronic inducible urticaria. So we discuss acute urticaria, wait and watch, treat. If it crosses chronic, whether they are spontaneous, then think for the secondary autoimmune and other etiology. Think of the arterial vasculitis if they crosses more than 24 hours and leaves pigmentation, and biopsy shows the changes of vasculitis. The next part is chronic inducible urticaria. Okay, they are not spontaneous. Sometimes it does not happen if the trigger is not there at all. That's a very good point. It does not happen if trigger is completely off. So this patient can have, while the spontaneous do not have that. It happens in respective trigger. Okay, these are usually short duration, and this is a very good clue. Urticaria happening less than 2 hours. Mostly try to see what induced it, and you will find the answer. Your chronic spontaneous urticaria usually 24 hours, while your inducible urticaria less than 2 hours, and arterial vasculitis more than 24 hours. So how important it is to talk to your patient. What is happening to you? Urticaria. How long does it last? Inducible, spontaneous, vasculitis, right? That easy. Sometimes it is not that easy. It's a gray zone, but it works. Believe me, it works. It definitely works. My urticaria is more than 36 hours. I had one ENT doctor friend, and his mother developed this arterial vasculitis, and it was secondary to Sjogren's syndrome. It worked. The treatment completely worked, and we are on right path there. Okay, so she was too much irritated with the urticaria. Urticaria is a irritating symptom. The itching is irritating symptom, right? So it is very important that patient quality of life goes too much down, and it has to be addressed. So here you have to take thorough history, but you should know what history you should take, and provocation testing help. This is a difficult provocation testing, and I will just go in a glimpse of that. Okay, this is the description of the test. You want to go for dermatographism, this is how you test it. You want to go for delayed pressure urticaria, weight like a shoulder sling with the weight of 7 kg placed for 15 minutes, patient records symptom over 24 hours. What happens to them, right? That is the pressure you induced, and the delayed pressure urticaria develops. Cholinergic urticaria, again, you have exercise part, cold contact, heat contact. These are the tests which can be done. Okay, when you have urticaria of less than 1 hour. See, now this is what we understand and what I've done in my clinical practice. If I get the inducible urticaria, I take help of my dermatologist. I cannot do everything in my OPD setup. Okay, but I know the college dermatologist who can do this thing with a proper interest, and we prove the case this is inducible urticaria, and then the trigger avoidance is the majority of the time treatment which happens. Okay, now we come to angioedema, and I think at this point, we all are here. Retaining in the class like this is a great thing, and you understand what is bradykinin mediated and what is histamine. So now I want you to go for bradykinin mediated angioedema. You know, they are either hereditary type 1, where there is almost complete deficiency, type 2, where there is almost what we say a functional deficiency, and then you have hereditary angioedema with normal C1 esterase inhibitor, and then you have acquired angioedema, and then you have further ACE inhibitor induced and all. So that's a history. That is fine, right? We have to prove 1, 2, 3, 4, right? So for the first test, what we know is the C4, which will be low in hereditary, this, and it can be here. So if it's normal, we have to think in this direction first. Then you go for the C1 esterase inhibitor. If it is coming low, it will be again low or normal. So if it's definitely low and there is a family history, you go for the type 1 as a diagnosis. And then you go for the C1 inhibitor function. It will be again low here, and in this, it can be normal and it would be again low here. Then you go for C1q. It will be low in acquired, but not here. Now, this is too much to take in 1 second. Okay. So what we do, let's make it in one of the MCQ. If C4, C1 inhibitor, and C1q, all three are low, it is acquired. Fine? Okay, fine. That's what we are starting with. If everything is normal, there is a possibility of hereditary angioedema with normal C1 inhibitor level. Fine, that's a great thing. Everything normal, this is the possibility. Everything low, this is the possibility, right? We are doing great here. Then you have this patient of type 1 and type 2. The major differentiator is a C1 inhibitor antigen. If that is normal, it is type 2. If it is low, it is type 1. Oh, that's a story. Okay. Sometime when you have bradykinin mediated angioedema, you can go for paraprotein. And I won't answer that why we are looking for paraprotein in a bradykinin mediated angioedema. Why we are looking for paraprotein level in bradykinin mediated angioedema? We are trying to look for plasma cell or the mastocytosis related disorder and all. That's why we are looking for paraprotein in this and the malignancy association, right? So this is again a very important clue what we all have to get with this, right? But if you know this is angioedema, then your workup is this. If you know it's urticaria angioedema, your workup was depending on duration and the inducible versus non-inducible, right? So this is the beauty of clinical medicine. First, decide what you are dealing and then you deal with that. Okay. If you get a patient with urticaria, why you are going for just complement level from very starting? No, it's not needed even, right? Because there is no bradykinin mediated syndrome here. If you are getting a patient with ACE inhibitor mediated angioedema, stop ACE inhibitor, treat the symptoms, and okay, you do not need complement level here. What you are trying to prove there? If it does not resolve, then there is a point you go ahead. So what is written in your book has to be understood with the things whether it is required in emergency or should we wait and then take a call. That's the clinical medicine we all want to practice. It's not that now I will send C1 inhibitor or C4 and C1q, paraproteins, everything at one shot. No, that's not clinical medicine. What is the point GPT can do for us, right? Our point is this, that these are the point we have to consider. Even GPT will tell, okay, don't do everything together. Don't blame me, man. Okay, very smart thing. Okay. So again, a part that whenever we are seeing a reference and from some department of this TK and all, mostly we tell refer to dermatology and go back. Okay, but we have to first rule out it's not vasculitis. Lost for 24 hours to 36 hours, result in scarring or pigmentation, and reported as painful but not much pruritic. I think it is both there. Whatever cases I have seen, they have pruritus and pain both, but theoretically they have more pain. In this, complement level helps specifically if they have angioedema without urticaria, right? You know, because it's a bradykinin process, not a histamine process. You are smarter now. Always raise the question of mastocytosis, specifically if they have flushing, hyperpigmented papules, urticate with the stroking, that is your dermatographism, and absence of angioedema. This is very important clue I keep taking. Only urticaria with GI symptoms and with dermatographism and a history of fracture, I will go for mastocytosis evaluation for sure. The fracture history is quite common in systemic mastocytosis. It's a very good risk factor for secondary osteoporosis. So we all should know it, and we should know how to make connect dots in MCQ. A so-and-so-year-old male who has AG reversal, who came with the fracture, okay, plasma cell disorder, multiple myeloma comes in picture, but has too much of the itching, urticaria, and dermatographism, mastocytosis is the second thing which should come in picture. Okay, that's how the things work. Okay, and that's how we will be learning. I think I'll take one discussion on mastocytosis, again a rare disorder, but I want you to diagnose all this thing in your life. Okay. BP, COPD, hypertension. Okay, we all are cool with that. They are routine. Okay, so they are a kind of a bread and butter. Okay, but for your biryani, these are the cases. Fine. Okay, now we come to the last part. That's the management of urticaria and angioedema. I will say we will just discuss principles, not much. Okay, so when you have, I will tell one line. Bradykinin mediated angioedema, steroid, epinephrine, antihistaminic is not much choice. And I think you are now frustrated. Tell us what works there, right? If it's histamine mediated, you are right there. Okay. So now this is very important. Topical glucocorticoid has no value. So when your patient has urticaria and you are giving topical glucocorticoid, don't do it. It is a process which will spontaneously heal, right? Why you are giving it? It has no value. Systemic glucocorticoid specifically help in the pressure urticaria, vasculitic urticaria, idiopathic angioedema with or without urticaria, chronic urticaria that responds poorly to conventional treatment, and any patient with a debilitating disease, you can give it. Steroid sparing agent, in my practice, it is omalizumab and cyclosporine. I use omalizumab a lot, not lot. I have few patients. I use it. It works beautifully. Okay, so we'll come to that order very soon. These are some trigger you have to identify when you're dealing with urticaria and have to tell that you have to use it regularly. The SOS antihistaminic does not make sense when you are managing urticaria. You have to have a planned antihistaminic. Okay, it is something I find that take that ondansetron when you vomit. What? It does not work like that. Okay, take it regularly so you do not vomit. That's how the anti-emetic works. Okay, we have to be very careful. Anti-emetic cannot be SOS. Come on. Okay, so these are few principles, and I judge people by that. Sorry, I love that. Okay, so this is very important point. How can you give antihistaminic all SOS? No, it does not work like that. A proper course, when your symptom resolves, slowly stop it. That's how it works. Okay, this is very important. NSAIDs better avoid, stress or sleep deprivation better avoid, heat, cold, sunlight not all the time, but when the acute episode is going on, avoid, and friction from clothing, concomitant infection, menstruation, or the perimenstrual period, you cannot avoid that. You can just note it down. Okay, these are the possible triggers. Sometimes can be avoided, sometimes may not be avoided, but it's always better to talk to patient that these are the things what we are failing, and this is part, right? So this is the patient communication. Now these are the drugs. I'm not going in detail. You have either IgE modulator, mast cell modulator, or the modulator at the nerves, blood vessel, and chemotaxis, right? So omalizumab is IgE modulator. IVIG sometimes can help. Plasmapheresis can help, and MMF helps there. We use it sometime, but my choice is still cyclosporine. Mast cell modulator are antihistaminic, corticosteroid, cyclosporine, tacrolimus, phototherapy, and combination of tranexamic acid with low molecular weight heparin. And these are the things which modifies this part. Okay. Even this is a beautiful table like this. We are not going in this picture, but allergy immunology is a beautiful subject. And believe me, there is no expert on this. Okay. I have never seen someone who is expert on this part, and we find it very difficult because we do not have yet a DM course in this. Fine. Okay. So this is what happens. Now, when you are managing a patient with CSU, that's chronic spontaneous urticaria, there is some scoring like this. I'm not going in detail, but for MCQ, if this score is less than 12, it identifies patient with poorly controlled. Lesser the score, poorer the control. That's what it does. Okay. So I give my all patient to do and to fill this. Because for chronic spontaneous urticaria, there is no blood biomarker to monitor. It is this score what we monitor. So we give them at the first point, and I keep asking that every month you keep filling it. And when you come to me for my follow-up visit, show me all the cards. Okay. So that works for me. If score is increasing, my treatment is working. If score is reducing or not improving, means my treatment has not worked enough or patient is not compliant to treatment. Okay. So this is something called CSU scoring. This is the point which may be important in your MCQ. This is the management plan. So when we start managing chronic spontaneous urticaria, means the urticaria is for more than 6 weeks and has no definite trigger. That is chronic spontaneous urticaria. I first start antihistaminic, can be cetirizine 10 milligram or levocetirizine 5 milligram, or fexofenadine is what people commonly use, right? Allegra and all, or it can be desloratadine. So anything. I mostly go for the levocetirizine or the fexofenadine, and that's the first thing I start. And we see that what is the response there. Okay. So if there is no control within 1 or 2 weeks and patient does no, sir, it's not changing much. So double the dose of this therapy. Okay. Or increase to the 4 times preferably of the levocetirizine. total dose. Okay, so you can give up to 20 mg a day and see what is happening there. Still no improvement 2 weeks. What happens in India? They change the doctor. Okay, so if you are that change doctor, what you are going to do? You are going to take the third step. And the third step for me in clinical practice is adding or offering omalizumab. Okay, I do that, but I discuss this is little expensive, but the quality of life is good. So some people are okay and some are not okay. It's in a way first line treatment with the recent guidelines. Okay, so if antihistaminic do not work, if they say no, ये injection तो नहीं लेना है, we don't want injection and all, add H2 antihistaminic, which can be famotidine, but again, I'm not very confident giving it in a long term, but it can be one of the therapy. Or you add Montelukast or Gefilocast, or you add H1 or the first generation H1 antihistaminic, which will make them sleepy. Okay, it may work, giving it a bedtime. Okay, these are the options you have to discuss with patient. I discuss this option as upfront. Some patient is, no, it is terrible. Doctor, do something for that. And then we use our ultimate weapon called steroids. Okay, starting with mostly 0.5 mg per kg and then slowly tapering it and stopping it. And if I'm starting omalizumab, this is the thing that 300 mg every 4 week for four doses, and after that we reduce it to 150 mg, and then we reduce the duration, and then we start tapering it. So I have a few doctors who are on this treatment and they are doing really good with the omalizumab. I'm not promoting anything. I'm telling you what is the right way to do the treatment. And this is something as a physician I manage, right? It does not require to be a DM rheumatologist to manage this case. If you understand this part, you can discuss with your dermat colleagues. So every case what I manage, I make sure a good dermatologist sees that patient and he or she discuss with me. This is the diagnosis we have made, and the moment we decide it is a CSU, we go in this treatment line. It works for sure. Okay. If not omalizumab, the choice can be cyclosporin, tacrolimus, MMF, Dapsone, and sulfasalazine. And someone will be laughing. You have an allergic disorder, you are giving sulfasalazine. Yes, you can give, doctor. Okay. This is the main crux of understanding medicine, that it is not that in allergy you do not use sulfasalazine. I have seen that very commonly. I have done that very commonly after my MD. This patient has asthma or allergy, na? Avoid sulfasalazine. It does not make a true sense as a clinician. Still, you avoid it. This is a medical legal system which works sometimes crazy. Okay. But you should be knowing someone has used is not wrong. It's actually the right thing to do sometime. Okay. So enough of all the mystery. We are going to treatment of angioedema, and we really want to learn that bradykinin induced angioedema, how to manage. So first, triage your patient. Triage your patient to green zone, yellow zone, or the red zone. Okay. So what is that? Is there any emergency? If the intubation is indicated, what we are discussing, first focus on intubation, do the part. If it's imminent, admit the patient and start medical treatment. What is medical treatment to be started? C1 esterase inhibitor or tranexamic acid. Tranexamic acid is available, does not works very fast, so may not be that helpful. C1 esterase inhibitor is very difficult. It is available now in India. Okay, but it is very difficult to get it, right? And if they have minimal edema, nothing much, stop offending medication and observe clinically. So in our patient, this would be the best management plan. But if you have given IV epinephrine, you have given steroids, you have given antihistaminic, I do not say you are wrong. It is completely cool to give that. Okay. Now, this is the part what we have to see, that if you want to terminate the attack, what is the treatment to use? So in your clinical practice, if patient has a bradykinin mediated angioedema, which is you think mostly ACE inhibitor induced, you give epinephrine, you give steroid, nothing worked. What you have to do is you have to call blood bank, arrange for FFP and give 2 units of the FFP. This will work. That's a treatment. Okay. So after this class, you know something which most of the physicians do not know. For bradykinin mediated angioedema attack, if that is severe, arrange FFP. Blood bank is the source of that, because C1 esterase inhibitor are going to take time. You even do not know who sells that, right? So it is going to be difficult. That's a treatment, but that's going to be difficult. So for terminating attack, it is going to be very difficult to arrange this. It is not going to be that difficult to arrange this. So arrange this. And I think you know a lot. So who are in this class from very starting, do you agree to the some point in the case what we discussed? What will be your therapy of choice? It will be FFP, fresh frozen plasma. Okay, because it has all this factor. which is actually helping in this patient. Okay, so this is the part. This is the part key in ACE inhibitor angioedema, you have deficient ACE. In hereditary angioedema, you have deficient C1 inhibitor activity. Okay, your fresh frozen plasma contains this both. That's why they are therapy of choice. That's the reason there. Okay, it is easily available, not very expensive. 2 units initially usually works, and you are doing great treatment there. So that's the difference. Now you know this is the therapy of choice. If you can get tranexamic acid, we use tranexamic acid as a preventive to hereditary angioedema and other angioedema problem. Okay, so tranexamic acid is a drug of choice. Again, usually universally available, inexpensive and safe. So sometimes you get a patient who has developed this angioedema, you are given FFP, and after that you want a preventive therapy, you are going to go for tranexamic acid, and which will be helpful. Sometimes it can be even helpful in terminating if it is given IV as a 1 gram IV immediately as a slow IV push over 10 minutes, and then you can repeat it after 4 hours if it is necessary. So now this is the point of knowledge which is there in your Harrison, but you have to get it. Okay, to be a very good physician. You only few people know, and you are now in few of them. Okay, that bradykinin mediated angioedema requires either FFP or tranexamic acid, which is easily available in our country. Okay, C1 inhibitor concentrate is available now, little expensive, but a good therapeutic option. Few of my colleagues have started using it. I have not used yet, but that's available option. This is a very common MCQ what you got about icatibant and ecallantide, which is again a therapy of the angioedema treatment. The very important point here is they are less useful for the emergent inpatient therapy. So in emergency, they are not much useful, and their trial results are not that great. Okay, there are a lot of publication because we know the reasons why there will be a lot of publication and discussion, but this is the fact. If I want to use, I will use either FFP or I will use tranexamic acid over these two names, but these two names are going to come in MCQ. So please Google what is the exact thing, the mechanism of icatibant and ecallantide. Okay, fine. So this is what I expect. No question, please. I'm just kidding. If you have any question, feel free to ask. These are some things we learn. At one point, I learned everything. After MD and certain time, I will say in between DM, I learn all this thing. And then I realized how ignorant I was to my textbook. Okay, so this is how medicine will keep evolving and we all will keep learning. We will end it here, and I keep requesting it that try to refer MedCAS WhatsApp group to as many of your colleagues possible. We are having a wonderful discussion there. And one more request, last thing, that before we conclude, I want to focus on this part. We are ready to take your clinical case. Please do present clinical case to us. Okay, keep it ready. Message me. I will coordinate everything for that. Sudha ma'am also has told that in from October she is ready to take classes for us, and I am pretty sure there is no better teacher than Sudha ma'am. Okay, in medicine, so you will learn for sure. So if anything with that, do message me. I hope you learn, and we will end it here. Good night.